Good morning. First of all, I express my sincere gratitude to the organizers who have given me a chance to discuss some basics about type 1 management. I am going to discuss about how to monitor, how to record, how to interpret the finding, and what are the target expectations. I'll be going through based on case scenarios. Here is a 14-year-old boy, Akash, a case of type 1 diabetes. He used to visit our clinic regularly, but recent months he is very much irregular and he is taking insulin injections and monitoring by himself. The parents have given full charge of insulin injection and monitoring to the child. And he brought a logbook which contained very few readings here and there, and that shows values between 100 and 200 milligram per deciliter. Child was put on CGM and asked to do regular GRBS monitoring, and he is advised a review after 2 weeks with HbA1c value. After 2 weeks, he brought an HbA1c value which was 12.6%. It was very high as per the international standards. So what is the target that is set for HbA1c value? As far as ISPAT guidelines is concerned, 7% is the expected HbA1c value in ideal situation. So many of our children, that is an unachievable goal. And if the child is on honeymoon phase, if the child is having some residual beta cell function, the expected target is even less than 7%. The target is set as 7.5% in resource limited situations. If there is inability to articulate symptoms of hypoglycemia, if the child is having hypoglycemia unawareness, and if the child is a high glycator, if his hemoglobin is having high affinity for attaching the glucose molecule, and if the child is having severe hypoglycemic attack, so the target is set as 7.5%. HbA1c is the mean blood glucose over the prior 3 to 4 months. Every child should have at least 3 to 4 measurements per year. That is, as of now, the only reliable long-term glycemic control measure. And elevated HbA1c levels are associated with chronic micro and macrovascular complications. And HbA1c, which is very low, that is associated with higher risk of hypoglycemia also. But HbA1c is not a replacement for daily glucose monitoring. So alone, it is not a good tool for optimizing day-to-day glycemic control. Aim is to have an HbA1c as low as possible, balanced with infrequent hypoglycemic episodes and the high quality of life. So if the child is having anemia, hemoglobinopathies like thalassemia and sickle cell disease, they have low HbA1c level. So that has to be taken into account. And as discussed before, there is high and low hemoglobin glycator phenotype within the population. His HbA1c is 12.6 and he has brought a well written and recorded glucometer value. So the logbook shows that most of the values are above 250. So they are having very high blood sugar values. So what are the targets that is set by ISPAT guidelines? So pre-meal blood glucose level should be between 70 to 130 milligram per deciliter. Pre-bed glucose level should be 80 to 140 milligram per deciliter. And post-meal value should be 90 to 180 milligram per deciliter. How many times we have to do blood glucose monitoring? Per day, average 6 to 10 glucometer readings should be ideal. And it should be done before each meal and before major snacks. And at bedtime to prevent nocturnal hypoglycemia, 2 to 3 hours after food to determine the appropriate mealtime insulin dose. During night, if you are using NPH as the basal insulin, we have to do a blood sugar at 2 to 3 am, and if you are using glargine or peakless insulin, we can do at 3 to 4 a.m. And whenever a child is doing an exercise, before, during and after exercise, you have to do a blood sugar measurements. During an intercurrent illness, and whenever you suspect hypoglycemia, and after managing hypoglycemia, you have to measure glucometer readings. This is a typical logbook that is used for recording self-monitoring of blood glucose. So there are pre-feed and post-feed values at breakfast, lunch, dinner, and if you are using a major snacks in the evening, you can include that also. Then at night, just before going to bed, and early morning, and whenever child is doing some exercise or during intercurrent illness or any other time, that also should be recorded. This child has brought his CGM report. It is a professional CGM. You can see that all values are literally sky high, above expected target range, except very few values at 6 o'clock in the morning. Everything is very high. What are the CGM targets? That will be discussed in detail in the evening class. But at least 70% should be in the target range, between 70 and 180 milligram per deciliter, and 30% can be above the target and 5% can be below the target. In this particular child, the average blood glucose measurement is 320 milligram per deciliter, and only 5% is in the target range. 1% is below target, it is not visible here, and 94% is above target. Akash was on human mixed chart. That I say is among our regime that is most unscientific method. It is 30 to 70, and he is taking 20 units in the morning and 10 units in the evening. His weight is 40 kg. Since he is already registered in our comprehensive diabetic care program of Kerala government, Mithai program, we have planned him to switch over basal bolus therapy with injection Lispro and injection Glargine. Regarding the type of insulin regime, human mixed chart is not preferred since that is a fixed dose combination. We cannot adjust the doses of basal and bolus insulin separately. That is the main problem of using mixed chart. Split mix therapy is also not physiological, so we can concentrate only on basal bolus. Basal bolus can be given based on the conventional insulin, in which bolus will be a regular insulin, 3 doses, pre-breakfast, pre-lunch and pre-dinner, and along with that basal insulin, injection NPH, given twice a day, morning and evening. Basal bolus with analogs, we can give rapid acting insulin pre-breakfast, pre-lunch, pre-dinner, and also most commonly pre-evening snacks, so at least 4 times a day if you are using a rapid acting analogs, and basal insulin as Glargine or Detimer once or twice a day. How to plan initial dose? The total daily dose, if you first diagnose a child as type 1 diabetes, he will be having a hyperglycemic state for at least 2 to 3 months. So the initial insulin dose would be higher. So the dose can be 1.5 to 2 units per kg per day. In an ordinary pre-pubertal phase, the dose will be 0.5 to 1 unit per kg per day. And in the pubertal phase, it will be 1 to 2 units per kg per day. And in post-pubertal phase, that insulin resistance will come down. So the requirement will be 0.5 to 1 unit per kg per day. And during partial remission, the dose will be as low as 0.5 unit per kg per day or even still lower. So that can be divided. At least 40 to 50% of the total dose should be given as basal insulin, either 1 or 2 doses, and the remaining can be divided as breakfast, lunch, evening snacks and dinner, at least 10 to 15%. And slightly higher amount of bolus insulin should be given before breakfast because of the dawn phenomenon, because of the action of growth hormone as a counter regulatory hormones, and the effect of basal insulin will gradually decreases in the early morning. So because of a lot of these reasons, the amount of rapid acting insulin given as a pre-breakfast may be slightly higher than the other times. So since Akash's weight is 40 kg, we have planned to start him on 1 unit per kg per day, and the basal glargine insulin set as 20 units and bolus Lispro as 5 units 4 times a day, 5, 5, 5, 5 before breakfast, before lunch, before dinner and before evening snacks. As a general rule, if you are giving rapid acting insulin, you have to give 15 to 20 minutes before meal. If you are using regular insulin, that should be given 20 to 30 minutes before meal. Bolus is adjusted to glycemia, meal content and daily activity. Basal insulin, if you are giving NPH, it is given twice a day, and long-acting analog once or twice a day. If you are using a smaller dose in young children, glargine should be given better as twice a day. It can be given before breakfast, dinner or bedtime. Anytime glargine can be given. So he came back after 1 week with his logbook after he has received basal bolus regime. Still, the values are not up to our targets. So how to readjust it? So by single look, it looks very difficult to readjust. So we have to take one by one. How and when should an insulin dose be changed? That is based on the daily pattern of blood glucose for a number of days. If the blood glucose value are above normal for 3 to 4 days in a row, or if there is no intercurrent illness, and if there is no intercurrent illness or stress factors, we can adjust. If there are more than 2 values below the target range, then you can adjust slightly more quickly. For small children, range change in the dose may be by 0.05 to 0.5 units at a time. In older children, by 1 to 2 units. So as such, the dose change should be 0.1 unit per kilogram at a time. If there is hypoglycemic episode, you should prevent this first by reducing the responsible insulin. So whenever a child is having hypoglycemia, you have to start quickly and you have to see which insulin has produced the effect of hypoglycemia, and you can reduce that dose. Don't change the insulin dose on a daily basis in line with every individual blood glucose reading. That is called as a roller coaster effect. If blood glucose can swing up and down like a roller coaster, so you will find impossible to understand which dose actually does what. What are the factors that determine the insulin dose adjustments? One is blood glucose level. Second is food intake. Third is exercise or activity. Fourth is intercurrent illness. So you can see this glucometer reading, the same glucometer reading. So we can concentrate on the pre-breakfast reading. So his pre-breakfast values are all high, 200, 218 and 206. That is above the set target by ISPAT. And you can again glance through the nighttime glucose. So the nocturnal value is also very high, 178, 188, 162 like that. So here child is having pre-breakfast insulin or fasting insulin level is high, but there is no nocturnal hypoglycemia. So this is called dawn phenomenon. What are the causes of dawn phenomenon? That is, one cause is increase in nocturnal growth hormone secretion. That is a counter-regulatory hormone that will increase the blood glucose level. And there is an increase in resistance to insulin action in the morning. Increase in hepatic glucose production and the waning effect of basal insulin. If you are using NPH or if you are using glargine, especially if you are giving a single morning day dose of glargine, the effect will wane during the early morning, very early morning. And here Somogyi effect is ruled out because there is no nocturnal hypoglycemia. So what is your plan? How will you change the insulin? The action is increase the basal insulin dose at night. Basal insulin, its adjustment is based on monitoring morning blood glucose levels. Then we can go to the stage 2. Post-feed breakfast was almost normal. So there is some problem if you analyze the pre-feed and post-feed values during lunch. The pre-feed values are almost normal, but post-feed values are very high. As per the SPART guidelines, post-peak values should be between 90 to 180. So all the three values are very high, above 200. So we have to change the insulin dose accordingly. So how will you manage it? So one of the greatest deficiencies in the diabetic management is lack of blood glucose value after meal. In almost all glucometer recording, you will get pre-breakfast, pre-lunch, pre-dinner, but the post-breakfast, post-lunch, post-dinner values may be lacking. Here, how will you manage? So increase in the pre-meal snacks, pre-meal or snacks bolus insulin, that is the action. How much we have to increase? It is ideal to use a combination of correction factor or sensitivity factor and carb ratio to determine the dose of rapid acting insulin given before meals or snacks. Insulin carbohydrate ratio is a well known 500 rule, 500 divided by total dose of insulin. That is the amount of carbohydrate in grams that 1 unit of insulin will cover. So roughly, to begin with, insulin carbohydrate ratio can be taken as 1 in 50. Another thing is insulin sensitivity factor. For rapid acting analogs, you use 1800 rule, that is 1800 divided by total daily insulin dose. That is the milligram in deciliter of blood glucose that 1 unit of rapid active insulin analog will lower. If you are using a regular insulin, you can use 1500 rule. 1500 divided by total insulin dose is the amount of blood glucose in milligram per deciliter that can be lowered by 1 unit of regular insulin. Akash is on 40 units of insulin. He is taking 1/3 cup of rice at lunch. So what is the correction dose? 1800 divided by 40. So that is 45. So 1 unit of insulin will reduce 45 milligram of blood sugars. So what is the target to be achieved? 90 to 180. So roughly if you take 120 as the target, 210 divided by 120, 210 minus 120 is 90 milligram. So insulin to be given is 90 divided by 45, that is 2 units of insulin as per the insulin sensitivity ratio. And 1/3 cup of rice is 15 grams. So that is 1 carb unit. Here insulin carbohydrate ratio is 500 divided by 40, that is 12.5. So roughly 15 grams. So the required insulin is 1 unit as per the insulin carbohydrate ratio. So you can use a combination. It is an approximate measurement. Total insulin requirement will be 2 plus 1, that is 3 units of insulin can be given to reduce this post-meal hike in blood glucose. Insulin carbohydrate ratio differs by the time of the day. More insulin is needed per gram of carbohydrate before breakfast and least at the bedtime. In preschool children, insulin carbohydrate ratio of 200 to 300 by total insulin dose can be considered. And protein and fat also require insulin for metabolism, and hence the concept of protein fat unit is also there. Then the most problematic is elevated blood glucose before lunch or dinner. Suppose you take that pre-dinner blood glucose level is high. So in general we can tell increase the previous bolus. But problem is if a regular acting and rapid acting analogs differ differently. If you are using a rapid acting analog, so suppose if you think that the child has taken lunch at 1 o'clock and child is about to take dinner at around 8 o'clock. So at least 6 or 7 hours has passed before he is taking a major meal. So what will happen? By that time, if you are using an aspart, Lispro or glulysin, a rapid acting analog, the usual duration of action of rapid acting analog is only 3 hours. So by 3 hours, majority of the insulin is used up and the body doesn't contain much of the bolus insulin. But if you are using a regular insulin, the action is around 6 hours. So by 6 hours, still some amount, even by 6 hours, some amount of regular insulin will be there in the blood. So if you are using a rapid acting insulin, that general rule, increase the previous bolus, may not applicable. So here the best thing may be to give a evening snacks, and you have to give a rapid acting analog before the evening snacks. Another thing is, if you are using NPH as the basal insulin, the peak action will be somewhere around between that. So that if the pre-dinner insulin, pre-dinner blood sugar level is high, so you can even increase the pre-breakfast basal insulin. But if you are using a peakless insulin like Glargine, we cannot alter like that. Then bedtime insulin, that is the next thing. Here you can see that even the bedtime glucose level is very high, that is 220, 246, 224. So what will you do? So increase in the, usually when there is a pre-bed blood glucose is high, the action is increasing the pre-dinner regular or rapid acting insulin. If at the time of bedtime, if the glucose levels are high, better to increase pre-dinner regular or rapid acting insulin. Then last is how to normalize nocturnal blood glucose. Should Akash be given bedtime snacks routinely? Routine snacks must be given if the bedtime blood glucose measurement is below 130 milligram per deciliter. If the bedtime blood glucose levels are low, a bedtime snack should be given. Then if Akash is taking a heavy exercise in the evening, then better to give a snacks. So the child may be having higher insulin sensitivity and produce hypoglycemia in the late night. And if NPH or any peaking insulin is given as a basal insulin, then also we have to give a bedtime snacks, because that will peak and produce hypoglycemia. And what bedtime snacks should be given? Don't give only liquid. Better to have a solid portion also, which contains some amount of fat. That will be having a long lasting effect. In what are the situations in which bedtime snacks should not be given? One, if you are using peakless insulin and the blood glucose levels are above 130 milligram per deciliter, then better not to give any bedtime snacks. And if the child is not doing any exercise also. What are the golden rules while changing the insulin based on the glucometer reports? Don't change more than one dose at a time. Better to change one dose and see the effect, and then you can change the other dose. Don't make large changes in insulin dosing all at once, and don't completely stop insulin. Wait for a couple of days between insulin changes so that you can clearly see the outcome. And when changing the insulin doses, a regular pattern of meal should be consumed every day. Sometimes the glucometer values may not be completely give you the actual problem. So glucometer value is just like a snapshot. You have to get a video to see what is actually happening. That is glucometer. You can see that this child came with some tremor and tiredness in the evening at around 4 p.m. But his glucometer values are fairly normal. So the morning value was 200, then the early pre-breakfast was 100, then pre-lunch was around 180, then pre-dinner was 200. So that completely missed the hypoglycemic attack that has happened around 4 p.m. So sometimes that will be deceiving, and if the child's glucometer reading and adjustments are not correlating together, it is better to do a continuous blood glucose monitoring and see, and that will help you in finer adjustments. So that will be discussed in detail in the next topic. So with that, I'll just conclude my talk. I am telling some basic, I have discussed some basics of adjusting the insulin dose based on the blood glucose monitoring, and I didn't give much importance to the diet and all these things. That will be discussed in an entire different session. Thank you very much for your patient listening.